Good evening, everyone. My name is Alejandra Gollarte. I am the Director of International Relations for Advancement at the University of Miami. It is a pleasure to welcome you to this forum on technology and healthcare at the University of Miami. I work closely with Dr. Armani, Director of the Center for Latin American Studies, who is in China right now attending a conference co-organized by the Center at Nankai University, one of China's top institutions. We're pleased to host this event at this beautiful facility as part of our ongoing partnership with American Society Council of the Americas. A few months ago, we held a very successful seminar on food security. So today's program continues a collaboration focused on cutting-edge topics that are fundamental to understand the present and future of Latin America and the Caribbean. The forum seeks to promote a discussion on how technology and innovation are enhancing access to healthcare in Latin America. This is a topic of central relevance for the Center of Latin American Studies. This fall, we expect to obtain final approval for a joint degree that we developed in partnership with the medical school, a joint master's in public health and master in Latin America Studies degree. This is a unique program in the United States because of the scope, which is broadly regional, and it has a practical side. All students will spend time in the region working on a public health project. Therefore, we are invested in promoting understanding of key aspects of healthcare in Latin America. We are very excited about this event, and we would like to thank again Nancy and Madeline for putting together such an excellent program. And thank you all for your presence. Thank you. Nancy?
Thank you, Alejandra, not only for being such a long-time supporter of the Council, but for being a dear friend as well. I'd like to thank Ariel Armoni and Scott Simmons and all the colleagues at the University of Miami for all of your support and collaborating with us again on a very important topic in this very beautiful building. I'd like to thank all of you for attending and those that are also participating via webcast, and welcome our panelists, Gustavo Menendez Bernales with Cisco, David Fox with DHL Global Forwarding, Jim Hogan with Medtronic Latin America, and Scott Simmons, of course, with UM's Telehealth Initiative. We also have a special guest, Congressman of Brazil, Rogério Carvalho, who will join us via video conference. He's a staunch advocate for technology and public health policy, whose perspective from Brazil and training as a doctor will most certainly prove very valuable. As many of you know, the American Society and the Council of the Americas continually strive to address the key issues and challenges that are facing Latin America and the Caribbean. And our commitment, and indeed our strength, lies in being able to unite leaders from the public and private sectors along to dialogue, but also to move forward key issues and affect positive change in the region. Along with topics like trade, energy, security, education, healthcare, has a very important place in the agenda of the Council, and tonight our intent is to foster a discussion on how healthcare access can be enhanced through current and innovative technologies and collaborations between the private sector, public, and NGOs. So let me thank our 2013 Miami program sponsors, Bunge, Chevron, HBO Latin America, Kroll Advisory Solutions, and especially Cisco Systems for all their support in making tonight's program possible, and to thank Telefonica, our global webcast sponsor, for allowing a global audience to tune in. Most importantly, I'd really like to thank my colleague, Madeline Johnson, who is the architect of tonight's program and who led an initiative across 3 offices to make it a success. So with that, let me briefly introduce and turn it over to Scott Simmons to moderate tonight's discussion. Scott is Director of Telehealth at the University of Miami Miller School of Medicine. He began his career in telehealth with the U.S. space program and worked with NASA to develop the first space-certified telemedicine system used aboard the Shuttle Endeavour mission. After completing important medical experiments at NASA, he spent time in the private sector commercializing technologies that he'd previously developed, and has spent more than a decade in academia, coming to the University of Miami in 2007. He's collaborated with institutions globally, including partnership with Southern Command in 3 deployments of telehealth for humanitarian assistance in the Caribbean and Latin America, and in supporting the Haiti earthquake relief efforts at the UN Medi-Share Field Hospital in Port-au-Prince. He recently served as secretary for the Latin American Caribbean chapter for the American Telemedicine Association, is a published expert, and a member of the editorial board of the Telemedicine and eHealth Journal. Scott, it's an honor to have you leading this evening's discussion, and thank you. I'll turn it over to you.
Thank you, Nancy. Everybody can hear me okay? So what we're going to do tonight is that, and I can't take any credit for putting this panel together. I just was handed a Ferrari, and hopefully I don't put it in the ditch, right? So this will be a slide-free zone or a PowerPoint-free zone. What we'd like to do is get some different perspectives on technology, specifically information and communications technology, and how that affects healthcare in the region. So I'll open with a few comments. I've been doing this telemedicine and kind of telehealth stuff for a little bit over 20 years, and so I thought I might share a few themes that I think are relevant just to kind of frame our discussion tonight. First is that if you think about it, the vast majority of healthcare transactions are cognitive. And a colleague of mine from Stanford would say it's 85 to 90% of medicine is cognitive, in that health professionals are processing information with their brain and making decisions about that then may lead to some physical intervention. But he says, 80 to 85, maybe even 90% of the time, we're dealing with information and processing that information in brains. Brains of very well-trained healthcare professionals. And I said physicians initially, but it's across the board, from nurses to technicians to physicians to scientists, all up and down. But the supply of these resources or these brains is limited, both in number, but also in distribution. You could say that they're scarce, but they're also unevenly distributed. So if you're in South Florida, for example, you swing a stethoscope, you're likely to hit 15 different cardiologists. However, if you're in rural Montana or in the Andes somewhere, that won't be the case. So they're very unevenly distributed. Canada's a great example. If you look at the population distribution in Canada, it's almost all centered near the US border. But there are people that live all the way up to the Arctic Circle, right? The reason why we started with this theme is that much of healthcare work is cognitive, is that technology is really good at collecting and moving information. So the promise here of using technology is that we can use technology to more efficiently distribute this scarce resource. In other words, we can use technology as a force multiplier for Mr. Hurtado and my Southcom colleagues might like that term. But we can basically squeeze efficiencies out of the system by using technology. So that's the promise of technology. And my background and most of my career has been involved in telemedicine or telehealth, and this isn't about telemedicine or telehealth. I think it's broader. It's really telehealth, telemedicine is part of health information and communications technology, or maybe even a better term would be is a significant but small part of what you might call a digital health ecosystem. So and I mention this because generally these different domains within health IT are treated separately. And so the telemedicine community and the electronic health record community don't often interact very well. So if I look at what I think of this digital health ecosystem, it's electronic health records, imaging and all the information systems around imaging, RIS, PACS, and things like that, laboratory and laboratory information systems, telehealth, and then now point of care devices. And it's interesting now what we mean by point of care, and I think technology is revolutionizing what we mean by the point of care, and I think we'll hear that with some of our speakers tonight, is because of technology and miniaturization and telecommunications and being able to get economies of scale of being able to leverage smartphones and other things like that, that we are completely turning healthcare on its head in terms of what the point of care is. So traditionally, health systems are set up around points of convenience for the providers or the physicians. So we travel to clinics, we travel to hospitals, so the patient goes to the expert. Well, with technology, the point of care can be really anywhere. And we're doing things right now, we can be in the workplace, and we have contracts with 2 of the major cruise lines where we're providing worksite teledermatology for fleets of ships around the world, right? It could be in the schools, and we have a pilot program in Miami-Dade schools. We're serving 9 schools, so the kids who are having low income, low SES kids in Miami-Dade County who don't have any other healthcare provider and who have parents that either don't work and often don't have transportation, it's very difficult to actually have a parent or guardian go get a child and take them to go see a physician. So we're providing care for them in the schools. The home, and we'll probably hear, I haven't heard what Jim's comments are going to be, but I'd imagine that people that have implanted devices aren't just in facilities and having their pacemakers interrogated from clinic facilities. Are probably doing that, if not now, soon from home. And really it's anywhere now, because it's amazing the amount of power, the supercomputer we have on our belts or in our purses or in our backpacks, in our pocket. So really the point of care can just be about anywhere. So I think that's a message that we need to think about too. And in doing this stuff for 20 years, and you might have heard this before, but I'll reiterate this because it's so true, is that success in this field, in any field related to technology and healthcare, is about people. It's not about technology, and that's where it succeeds or fails, is based on humans. So one of the themes of our discussion tonight, it will be opportunities and challenges in using technology to improve healthcare in the region. I would like to offer up kind of my viewpoint on that to start, not to cloud anybody else, but I think, excuse me, I think some of these following are some of the opportunities. So I mentioned the corporate or work site or occupational. I think that's big, especially multinational corporations that operate in the Caribbean and Latin America. That's an increasing population of customers for us, is being able, because at least in the United States, who pays for healthcare? The patient's not really the customer, it's usually the employer, right? And so they care about time away from work. They care about the inefficiencies in the health system. The inefficient time spent driving to the physician's office, waiting in one waiting room, moving to another waiting room, going to a third waiting room, having some testing, that's an incredibly inefficient process. I mentioned schools. I think that's another opportunity. And one thing that's really starting to boom in the United States anyway is what I would call virtual staffing. And it's really started with telestroke, which is something we and many other people are involved in, where hospitals, and not just rural hospitals, but many suburban hospitals, like Palm Beach County, for example, this was an issue. Palm Beach County, one of the most affluent counties in the United States, had trouble getting their hospital emergency departments to be covered by neurologists. They didn't want to come in and cover the emergency department for a variety of reasons. But so it started in neurology, and so now there's these telestroke services that have developed. And so we're just, with full disclosure, we're an academic provider for the largest corporate provider of telehealth services right now, a group called Specialists on Call. And so their service level agreement is they guarantee access to a stroke certified neurologist within 15 minutes of being called. They get the CTs and the video connection set up to the patient's bedside, and they make the decision as to if it's a suspected stroke, if it's a clotting or bleeding stroke, and if it's a clotting stroke, they push this magic clot-busting drug called TPA, which you may have heard of before. But what they've found, and others have found, is that hospitals aren't just having trouble getting staff neurologists, they're having trouble getting staff psychiatrists, staff dermatologists, staff ophthalmologists. So I think this virtual staffing is something that's big, and I'd imagine it's an issue in much of Latin America as well. I think tourism and medical tourism are other opportunities, and maybe because we've got people, since tourism's such a big industry in our region, and we've got expats kind of moving around and have multiple homes in multiple places, that may be an opportunity for collaboration. And another one that's very near and dear to my heart, and it's something that was mentioned in my brief introduction, is humanitarian assistance and disaster relief. We've done now 3 deployments with Southern Command in humanitarian assistance, and we collaborated with them and many other people in after the Haiti earthquake. But I think there are many organizations, whether they're churches or other non-government organizations or other charities that do work in impoverished part of this region, and they're really limited to the time they can spend on the ground. So let's say a surgeon, for example, agrees to do some sort of like cleft lip, let's say cleft lip, cleft palate surgery. They go in the first 2 or 3 days, they end up spending screening patients. They do the maximum amount of surgeries they can do for 2 or 3 days, and then they're out, right? I would think it would be much more effective if you could screen on the front end, optimize your surgical time on the ground, and then continue to follow up patients afterwards. And so I think that's an opportunity too, is in this humanitarian assistance area, because I think it's a lot more sustainable, especially if we build capacity in countries for people to support their own citizens with telehealth, and then just add in the extra physician capacity as needed remotely. That's something that I really believe in, and it's a real area for people to want to be willing to collaborate. So challenges real quickly. Regulation's a challenge, and I mean in several respects. Regulation in our own country is a challenge because innovation is far outpacing regulation. The FDA has no idea what it really wants to do with these apps and devices that plug into smartphones and that. Well, I think they have a better idea now than they did, but I think it's overwhelming, and the regulation in terms of device regulation and certification is in tension with innovation. But also in terms of one of the risks that we're concerned about is there is a lack of law on the books in different countries in Latin America that prohibit telehealth in these sort of interactions, but we're still concerned that may change, right? So if we're going to do anything, we might want to get the blessing of a minister of health if there's no legislation, but that's not protection, right? So I think that's a potential challenge, and not to mention import-export controls and other issues like that if we're doing cross-border things. Inertia is another challenge. You know, an object at rest tends to stay at rest, so people are reluctant to change the way they do things. So that's a challenge. Funding and payment is a challenge. There's a concept of exhaustion of goodwill, right? So people are willing to give charity care, reduce rate care, but they do have to pay their bills. And many projects that we've tried to start in different parts of the world have when it got to the point of somebody actually funding it, that's kind of where it falls apart. So that's a challenge. And then there's different, I guess you could say, socio-cultural, political differences between different health systems and philosophies about healthcare. That's a challenge. And to me, the biggest one, and it's one that's a challenge to us in the United States, is in the workforce. It's really difficult to get trained people to stay with, well, to find them in the first place and to retain them that have backgrounds in health IT, telehealth. Those people either don't exist, they're not being cranked out of degree programs. And actually, I was at a meeting not too long ago with the CIO from Hospital Corporation of America, and they've actually built their own academy internally for training people in health IT because there's such a shortage of workers. So I know that's not just an issue here, that's an issue throughout the Americas. So I think that's a challenge as well. So with that, I think I will turn it over to Gustavo. I think that's the order we had on the program, right? To make some opening remarks, and you can choose to come up here or stay seated as you look very comfortable, your choice.
Hello? Yeah. Well, this is a fascinating topic, and I've been sharing many efforts with Scott in the past, and we have worked in the region upside down. So I would like to share some of these ideas and some of these progresses that we have achieved in the region with you. Basically, we understood telemedicine was a big challenge for Latin American countries in general, and we thought technology was key to jump this limitation that we have in our countries. The statistics that Scott mentioned about the uneven distribution of doctors, I think we basically discovered that our key element here was the lack of access to the specialist doctors in our countries. Most of our countries have around 70% of the specialists concentrated in urban locations, and of these 70%, almost 80% are in the capital of the country and in a very reduced geographic radius within the capital. So for citizens, it's very difficult to access these specialists unless you live really in the heart of the capital of the country. So we have been developing a telemedicine proposal around one of our key technologies. Cisco decided to develop video 10 years ago as a key technology for the future. We invested a large amount of resources in developing several technologies around video. I don't know if you're familiar with telepresence, which is our core technology for high-end video. And around telepresence, we have developed also different technologies that are integrated with each other. And today we have a very strong foundation for video that we are applying to telemedicine. And it's been extremely successful so far, and we have overcome these limitations. And we developed a value proposition that I think it's been proven and it's very successful so far. And probably I can give you a few examples, but I think, again, going around the limitations of the access to specialists in our countries, we implemented this technology, and beyond having worked in telemedicine before, especially in asynchronic telemedicine, we are moving into what we call high-definition video interaction for telemedicine. And that is the dimension that we are seeing with the highest impact in our countries. The ability to connect to a specialist that is sitting in the capital of the country from 500 kilometers, 1,000 kilometers, and having immediate access to this specialist makes a big difference for the system. It's not about equal access only, because this is providing equal access, but more importantly, is providing timely access. If you're a citizen living in, I'm going to use the example of my country, Argentina. If you live in the north of Argentina, you still have the ability, and you have a kid that is sick, you can take this kid and still have the access to the best specialist in Buenos Aires, in the National Pediatric Hospital. But it will take you several days to arrive there and a lot of resources. With telemedicine, you can have instant access to the same specialist, and that provides not only equal access, but timely access, which is key for healthcare. And that's where we are seeing the most value. Lately in Chile, we helped the government after the earthquake, and they were having significant problems in healthcare services in the affected area. We managed to put together a program down there to provide telemedicine, and we managed to reduce a waiting list that was accumulating 2 years of wait for some patients to 48 hours. So every citizen living in the area had the ability to see a cardiologist in less than 48 hours, while in the past they were just waiting, in some cases, nearly 2 years to be served by a specialist. That's the type of program we are trying to put in place, and so far we have been very successful. We are working with both public sector in our countries and also with private sector, and we have been very successful in finding this productivity, this high impact deployment of telemedicine. It's not only providing savings, but it's also providing a lot of opportunities for doctors to work closer to the patients, also to use the same technology for learning, for continued medical education, which is also another great opportunity of this, is when you have these telemedicine programs, doctors can really get together with the best specialists in the country, and that really makes a big difference. And the other thing that we have done through telemedicine is trying to lift some barriers that we had in the past, especially with the cost. We are seeing 3 concurrent factors right now for making this easier and more likely to be implemented. The 3 factors are basically the consumer markets. People are getting very used to video. You can have video in your smartphone. You can download video from the internet, and people are used to video chat and to use video calls more and more. So that is making the market more mature to use video in one hand. And when I mention the market, I'm not talking only about the patients, but also about the doctors and the nurses. So everybody is familiar with video. That's the first one. The second one is the maturity of the video technology, which has really developed very well in the last few years, not only in terms of quality, but also in terms of cost and affordability. And the second one is the infrastructure that has also been developed in our countries extensively. We have fiber, we have national plans for connectivity, we have private sector deployments also for fiber and bandwidth availability everywhere. So these three factors are helping the implementation of these telemedicine programs and are really making a big difference. We have also been discussing these opportunities with multilateral organizations, and it seems that everybody is really getting together in this. So we see a lot of momentum for telemedicine, and we are seeing a lot of progress. So, beyond the barriers, I think we managed to implement significant projects, and we also managed to combine a value proposition that is not only for big investments. We have some, as an example, we have some programs for telemedicine with using WebEx, which is our web conferencing technology, for $39 a month for an HIV consultation with a specialist in one of our countries. And we also have, high definition, high-end programs with governments tackling, for example, national pediatric hospitals. Or now we are working with the oncology national hospital in Peru. So we are really mixing and matching every opportunity we are seeing, and we are really getting to make the vision that we had a reality and we see more and more the opportunities coming forward and really giving us more opportunities to implement in the near future.
Thank you. Well, I know we're out of order, but why don't we just, a logical way is to come like this way. So.
Outstanding. My name is David Fox. I have been with DHL for 27 years, and the last 9 or 10 years has been in the life sciences and healthcare sector. So I've really seen the logistics commitment of the organization started back in 2000, where here in Miami, we had our first life sciences and healthcare customer conference. And we talked about a lot of things about where the industry was headed from a logistics standpoint, from a temperature controlled regulation standpoint. You talked about earlier, and the importance of getting the product there on time and in the right condition. And we certainly have seen evolving technologies over the past few years. We have an innovation center in Bonn, Germany, where we've, over the last couple of years, been testing some RFID technology called Smart Sensor. And this week alone here in Miami, ironically, we had our 13th annual Life Sciences Conference, and where we rolled out a standard cold chain product. And everybody in this room has a need to understand how the product moves. And whether it's air freight or ocean freight, a lot of it is temperature controlled. And one statistic that alarmed me that today 25% of life science product moves as cold chain. Over the next 5 years, that number is going to increase to 50%, which is very, very alarming. So the investments in innovation and the rolling out of a new standardized product is something that we did this week. It's called ThermoNet. So every temperature-controlled shipment that's going to be moving anywhere in the world, essentially, if you've got product being manufactured in India, moving to Chile, DHL, as a part of our standard portfolio, will be, through the use of the ThermoNet product, will have smart sensor technology affixed to the product. And that says a lot about how far we've come from a technology standpoint within the logistics industry. As the leader, we're very pleased. We had over 200 companies here in Miami attend the conference this week. Got into a lot of questions about this technology. What is it really going to mean to the end customer in remote places in Brazil or Argentina? From my perspective, it's very exciting to be a part of this new product launch because it's important to understand, and I had a delay flying into Miami today myself, where you're sitting on a tarmac, you look out the window, and you see pallets of cargo sitting there, And it wasn't 95 degrees where I flew in from, but you can imagine, right, in the hot summer months, and you know that there are generic drugs sitting there on that tarmac, what is that doing to the product on the inside? So essentially, ThermoNet is a technology through smart sensor that's going to allow large corporations to understand what the ambient temperature is of the product throughout the life of that shipment. And that's something that's very, very important for all of us, especially when there's patients in remote areas throughout Latin America or anywhere in the world that has a need for a drug. We want it to get there on time and in the right condition. And if there's a deviation, to be able to track that through those tighter regulations that are becoming more and more apparent every day through a number of agencies, right? And so we're excited about this product, and we think this technology is first to market. We know it's first to market, and as the industry leader, we're excited about where we're headed with the technology component.
Well, thanks. Good evening, everybody. I guess before I start, I should just actually say thanks to the council and to the university for getting this all organized. So Madeline, Nancy, Alejandra, thanks for getting it put together. I think that shows that there's a level of interest if this many people are going to be willing to risk getting out in the rain and actually even maybe risk the start of the Heat game tonight, to come here. So obviously it's of importance, but I think the topic's of importance from a professional standpoint, but it's clearly of importance to everybody in this room from just a sheer personal health standpoint. So I'm going to make some comments from the standpoint of a medical technology company, from Medtronic's standpoint. Now, Medtronic is the world's largest medical device company, and I suspect a lot of you don't know what Medtronic is, and don't be surprised that you don't know the largest company. And the reason is because we make the types of technologies that a physician generally chooses for you. If you need a pacemaker anywhere in the world, or a neurostimulator, or a heart valve, or a stent in your heart, or these sorts of things, generally you'll have a discussion with the physician about the disorder that you have, but it rarely gets to the point of discussing with them what brand of pacemaker are you going to put in. That's usually left to the physician. So that's why you haven't heard of Medtronic, even though we happen to be the largest medical device company. So I can talk about a lot of things when I talk about technologies, but what I thought I would do tonight is confine my comments a little bit to the area of information technology, because I think there's nothing that has made as profound a change on the way we do business as the increase in information technology over the last few years. And Scott and Gustavo have mentioned a lot of topics that are related here. But let me comment on those in three broad areas, and I'll try to do this briefly enough so we all do get to the Heat game on time. But the first area would be on how is information technology helping us diagnose patients? How is information technology helping us ensure that the technologies that we give to patients actually work the best that they can? And the third, and it's particularly relevant for a place like Latin America, how are we using information technology to ensure that patients that need a technology get access to it? Okay, so kind of those broad themes. So let's first of all start out with diagnostics. I mean, everybody in this room has had this experience, right? You have a problem, and so you schedule an appointment with your doctor, and what happens when you get there? You don't have the problem anymore, right? I mean, that's always the case, isn't it? And so you go there and you say, well, doctor, I had this problem with my neck. And he says, well, how's it feel now? He says, well, it's fine now, but I had this problem with my neck. And there's nothing you can do about it anymore because the problem is gone by the time you get there. Well, cardiology problems are much the same way. Your heart doesn't just suddenly stop working generally. It's a progressive thing. You start having symptoms, but, you go to the doctor, and that day you might be perfectly fine. So it makes it very difficult to diagnose, what is it that the patient actually needs. So an example of how information technology is changing that is that we now have patch technologies that, the person sticks onto their chest, much like a large Band-Aid that they stick on, and that will measure their cardiac output for a period of a couple of weeks. If you need to actually have it be longer, we have models of that actually get implanted underneath the skin so it can monitor your heart for some months. So then the patient can now come to the doctor and say, last week, it was around 10 o'clock on Tuesday, my heart started having this fluttering feeling. And then the exact same thing happened again about midnight on Friday night. Well, now the doctor can download all that cardiac output of what's happened in your heart over the last week or month, whatever that period is, and pinpoint exactly when you were having those problems, and therefore be able to make an effective and an accurate diagnosis not just sort of guessing at what the problem was that you had at some point. And then what's the effect of that? The effect of that is that they can actually treat the patient much earlier on in the process. And as we all know, if you treat patients earlier, the outcomes tend to be better. So now let's move that forward to the patient getting an actual therapy. So now assume the patient gets a pacemaker. Well, for those of you that aren't that familiar with pacemakers, you probably think of a pacemaker as something that just sends out an impulse to the heart to keep the heart pulsing. Well, 50 years ago that was true. Today, pacemakers are just very, very sophisticated battery-operated computers that you put into a person's chest that still can put out an impulse too. But they don't just do that, they also monitor the heart at all times. And they're monitoring the heart to determine, is the electrical impulse that's supposed to come in the heart actually coming when it's supposed to, within 100th of a second. And if the right impulse is generated by the heart, the pacemaker does nothing. Because obviously, if you can let the heart do its own work, that's much better. And of course, if the pacemaker does nothing, then it lasts a few years longer as well before the battery goes dead. But if the right impulse isn't generated in the heart, then the pacemaker sends out a signal and gets the heart cascade to start taking effect. Well, as it is just a sophisticated computer, it has to be programmed. And it has to be programmed right to the individual patient's particular needs. And that's why patients with pacemakers have to come back every 3 or 6 months to get them kind of reprogrammed and readjusted as the patient changes over the period of their life and as they get older. Well, now, if the patient, as you do say, is 8 hours away in a village in Brazil someplace, that may very likely be 8 hours, as Gustavo was saying. Those specialists are in the big cities. That may be an 8-hour trip for the patient to get back to the doctor to actually have that reprogramming done. That's a big hardship. Well, those pacemakers today come with a little box that sits alongside of your bed, and for 8 hours a day while you're sleeping, it's constantly monitoring and sending back the information about how your heart is functioning, how the device is functioning, even if you're getting any fluid buildup in your lungs. That's being constantly sent off for 8 hours a day. So the doctor can, at a certain period of time, check on how that patient's doing without the patient taking that drive for 8 hours back, very often to find that nothing needs to be changed. All that time was wasted, both on the part of the doctor and the part of the patient. Now that can be monitored. It actually can be set up such that if any particular things change, the doctor will automatically get an alert. And so, therefore, oftentimes the doctor knows that a patient's cardiac condition is changing before the patient even feels it themselves. Now, what I'm talking about here is that the product hasn't changed at all. It's the same product that they're getting. But what has changed? Information technology has changed such that now the right patient is getting the product because they were being diagnosed properly. And now that same product is functioning much, much better for the patient. It's much more efficient for the patient. It's much more efficient for the doctor. And the only change is information technology, but the same product is being done. Now let's look at about how do patients actually get the access to the technology. That's one of the big issues. One of the big issues, and let's stay on the cardiology theme for a second. If someone's having a heart attack, if I right now grab my chest, fall to the floor, and go unconscious, probably most people in this room would be able to diagnose, what's going on here. But most heart attacks aren't like that. Most heart attacks happen where a person just starts having a small artery in their heart being blocked and a small part of their heart is not getting adequate blood flow. Well, the heart is no different than your finger. If you put a tight band around the end of your finger, it'll turn purple. But as long as you take that band off in a couple of hours, blood will go back into your finger and everything will be fine. Your heart's exactly the same. You can have a heart attack, and if you don't revascularize the heart within a couple of hours, well, that part of the heart will die. The person probably won't die, but their heart won't work so well anymore, and they'll have a cascade of events that starts deteriorating their health over time. But if you can't get them to a hospital within that 2-hour period, you can revascularize their heart, and they probably will survive that heart attack with absolutely no debilitation whatsoever. So what are we using to do with information technology to ensure that happens? Well, what we're doing is we're setting up in the periphery around many of our implanting centers at all the referral emergency rooms and referral clinics, putting in place EKG machines that are connected into the web. So all the nurse or the local GP at that local clinic has to do is put the pads on the chest in an appropriate spot when a patient comes in. And within 10 minutes, that EKG will be sent to a cardiologist, and in 10 minutes, they'll get the results back of knowing whether or not that patient is actually having a heart attack. Because believe it or not, most people don't know when they're having a heart attack. They just feel bad. They feel really bad, but they feel bad. They're lightheaded, have an upset stomach, they don't know what it is. They've never had a heart attack before. And it's really hard for someone other than a cardiologist with an EKG to diagnose it. But in this environment now, through telemedicine, they get a report back from a cardiologist within 10 minutes, so they now can decide that, no, you're just having heartburn, or in fact, you're having a heart attack. We've got to get you over to this other hospital, and we need to get you there within this next hour so you can be treated. So again, the therapy is exactly the same, isn't it? No difference in the therapy here. It's the same products being used, but it's information technology that's allowing the right patient to get the product, to have the product work better when they get it, and actually have more of the patients have access to getting the technology at some point. And the only difference is information technology. I know I'm supposed to keep it within 5 to 7 minutes, so I'll stop. But I'll just leave the comment with one final comment about it, because it's one of the issues that I see going forward that I think has a lot of bearing here, which is what to do with all of this information going forward. I mean, virtually none of the technologies that we sell, whether it's a pacemaker, a heart valve, a stent, a neurostimulator, an insulin pump, anything it might be, all of these products have the capacity to have some sort of monitoring technologies embedded into them. Now, today, there's not that much of it, but I can imagine a day in the very near future where virtually every person walking around is going to have some kind of monitoring going on of something in their body. What goes on with all of this information? This is a monstrous, massive amount of clinical data that is being generated every day. Now, where is all of that going to go? Who's going to maintain it? Who's going to store it? Who's going to view it to determine if there's some clinical significance to what they're seeing? How are we going to keep the people that can actually make a good clinical diagnosis to see it when they need to see it? And how do we keep other people that really have no business seeing it from seeing it? How do we transfer it across borders, and maintain security?
That's really a sensitive topic this week or last week, right?
Yeah, that's right. So, just the sheer volume of it. The amount of data being generated, or that will be generated when millions and millions of people have reams of clinical data being spewed out of their bodies at any moment, is something that I have no idea how it will be controlled. But I think it's one of the big technological challenges that the benefits of information technology are going to be posing for us in the years ahead.
Well, thanks everybody. Do we have any questions or comments at this point from the audience? Because I want to make sure that we have time for interaction, because we have plenty. I know I have plenty of follow-up and discussion, but I want to make sure if you had any questions or comments, that you had the opportunity to do that before we got into it here.
Hi. I'll be very brief. We've talked a lot about leveraging technologies for the supply of healthcare, very specialized healthcare services. But what about on the reverse end? What about the user experience for the patients, the consumers of these specialized services through technology?
I think it's kind of in your area about, the
Well,
kind of experience that patients
I didn't
have.
fully understand. I didn't fully understand the question. Because we're talking about this dyad of
when you're talking
patient
about
and
the
customers.
Talking about the patient experience. So what is it like for the patient who is consuming the telemedicine?
Oh,
service?
yeah, I can comment on that. Okay, that's what's interesting, is that we get that question all the time, and usually it's somewhere upwards of 98 to 99% patient satisfaction, usually because they're the ones that are accruing the benefit of convenience, right, and earlier access to care. So I wasn't sure if you were getting into UI, UX, or what you were getting to, but you were talking about just general patient experience with telehealth has been extremely positive. And I don't know if you have anything to add to that.
Yeah, we have the same experience, 99% satisfaction, sometimes even comments on favoring telemedicine compared to presence interaction with doctors. Because they said, sometimes patients said, they pay more attention, they are more relaxed, they can really dedicate time, they listen to me a lot more. So our experience is, in terms of patient satisfaction, is unbelievably good. It's beyond what we can imagine. And also, what Scott says is also true, is they are the ones that are benefiting the most from this. They are saving time, they are saving travel, they are saving expenses, they are saving many, many complications. We have done a program to support post-transplant for kids treatment, and we have witnessed testimonies from parents saying, crying over the microphone, saying, really, that saved my life, because I used to have my other kids left alone in the city while traveling 1,000 kilometers. I lost my job because of that. I had to stay longer than expected in the city because my doctor was transplanting someone else in emergency, so he was not available to see us. We had to wait for 3 more days. That type of complication, and they're really enjoying all this. They are really the ones that are benefiting the most. So we are seeing a lot of extremely positive feedback from the patients. There is a twist to this, that is when you talk about telemedicine to the home. This is a little bit more complicated, and I think this is the next chapter, and it brings a lot of different dimensions and complexities for the future. So for the time being, we are concentrating in connecting institutions, hospitals, where we can see and find doctors, and also institutions to medical practices, or even to the home of the doctor, but not yet working on the direct relationship of the patient from the home. But I think it's the next chapter for the evolution of telemedicine. But so far, it's been extremely positive impact.
I think we had a couple. I'm not sure how we're going to provide the microphone. Okay, we have one back here. All right, sorry, that's where the mic is.
Hi, it was an interesting point you mentioned at the beginning of the talk, was that it's not just about technology, but the people you have. And my question goes towards, what's your vision in developing countries, where it's not just about the technology, but also you have to have the infrastructure and the skilled people that are like put together, like the patient and the physician in a capital city, for example. So what's your vision on public health, where the technology is not as mature, and in particular, for the example of telehealth, that you have the community is segregated into rural places where the infrastructure will not be available, or what's your vision on that particular case? And also, you mentioned about who will manage all these data, who will manage all these infrastructure, databases, networks, and in developing countries, and how far down the road you see that this will be a potential reality.
Well, I would defer to the superior gestalt of my corporate colleagues that are actually doing more day-to-day work in Latin America regarding the infrastructure and the education level. But that was one of the things I pointed out, that's a challenge even in the U.S. is that kind of the health IT workforce. But any of you care to take that?
Well, maybe I'll make a couple comments, and then others can chime in as well. The question you ask brings up multiple different questions, multiple different answers. One of those answers relate to the amount of money that is being put into healthcare in other countries, and clearly the amount of money that's being put into healthcare in Latin America, if we specialize here on that tonight, is certainly much less than in many other areas of the world. That being said, there's absolutely world-class healthcare available in every single country in Latin America. I mean, that's an absolute truth. But in Latin America, just like any place else in the world, the vast majority of healthcare isn't really used very effectively, because there's an awful lot of people that are spending time in those healthcare environments that don't really need to be there that particular day, or that are getting extra care beyond what they really had to get if they were treated more effectively the first time. And so I think that's one of the big benefits that the health technologies can bring, is getting the patients that need to be there where they need to be and being treated appropriately when they get there. Now, all that being said, technology won't save us. I mean, we have to be working with governments to get them to recognize that a healthy population is a wealthy population. A healthy population contributes to society rather than pulling money away from society. And we have to get governments to recognize that healthcare doesn't cost money. What costs money is unhealthy people who are not working, are not paying taxes, who are still drawing something away from society, because there's never an alternative between this therapy or this drug and nothing. There's always an opposite cost. The opposite cost is that the person's consuming other hospital resources, or they're not working, or their family members are taking care of them. There's always an alternative cost. So what we have to really be doing is working with the the overall governments to be trying to develop the kind of infrastructure that will enable more patients to have access. But that's the overarching issue. The underarching issue is the fact that there is access there today. We just have to make sure that the right people get to the right spot.
David, you care to?
I just think from an investment standpoint in Latin America, this is an area it's been a focus in the logistics industry in terms of training, investment in infrastructure to ensure that people know how to handle the products from a competency standpoint. I think that's really critical in these emerging markets where there's where the growth is going to be in the future. I think it speaks volumes of the importance of people understanding how to handle products to make sure that the end patient, the end user, receives them in the right condition. So I think investment in that area, it's not going to be in the United States or in the UK or in Germany. It's going to be in the Brazils of the world, and that's where our investment and research has led us to go in that direction.
What I would like to add is, in our experience, that the infrastructure program was something of the past. I don't see that anymore. I think we are meeting with ministries of technology in some of our countries that are asking us for help because they do have the infrastructure now, and they don't have the content. They don't have the programs to have social impact. They have the vehicle, but they don't have anything to put on top. And that is a combination of both. The investment in infrastructure that has been taking place in Latin America, not only funded by our own governments and countries, but also from multilateral organizations like IDB. They are now looking into how do we use this infrastructure. We already laid it down, and we have it there. So I think that is one element. And the other element is what I mentioned before, is that the technology now is affordable. And you have a combination of technologies. You don't need to go high-end all over the place. And if you analyze our cellular coverage in Latin America, I think we are reaching 70-75% of the population. So really, access through technology is not a problem anymore. I think it's more about how to implement these programs. It's about the change management. I always said the technology is the easy piece here. We can lay down the technology pretty fast and implement all these functionalities easily. It's more difficult now to make the change program happen and convince people about the new way of working, shifting some paradigms that are there for long, changing the model of the healthcare delivery as well. We've been discussing with the Ministry of Health in Chile when they were planning on rebuilding the hospitals that were down during the earthquake, and they said, we cannot rebuild the hospitals like we designed them 50 years ago. We have to design them for the next 50 years. We have to consider technology and IT component here. So we have to do smaller hospitals, less concentration. We have to distribute them closer to the people. And we have to connect all of them so they can really share all the resources and really get the productivity that technology is allowing us. So in our experience, it's not a barrier anymore. Infrastructure is there, programs are ready to be deployed, and the technology can adapt. We can connect video with 384K and in one end, and in the other end with the high definition 6 megabyte connection. And we can combine all of that, and we can make a doctor work with a patient or a doctor work with another doctor using this technology, and it's very affordable. So in our vision, I think it's more about change management than infrastructure.
We had another question or comment?
Yeah, I have a question regarding the role of the regulator in all this boom of technology or extra data coming into the play. Because if there are more intelligent devices and everybody carry a mobile phone, and probably in 2 or 3 years we'll have a ton of applications running in our phones to provide healthcare data. Who will be doing the interpretation of that data? The brains that you mentioned at the beginning of the conference will become relatively in very high demand eventually. So I imagine that probably the technology itself will take care of the data and a potential diagnostic. So if that is the case, where is the regulator doing the proper measures to ensure that that boom of applications will be really at the standard that everybody deserves, right? Because it's healthcare. So is the FDA running at the right speed in terms of the advance of technology or not?
Well, yeah, I'll take that one on, I guess. That's not really a yes or no answer, but as I mentioned before, there's a tension between innovation and regulation, and I think regulation is lagging behind the innovation, right? But the standard response to that, though, then is to be hyper conservative or hyper restrictive about how we use information. And so, for example, we have this HIPAA Act in the United States, Health Insurance Portability and Accountability Act, which has struck, I think actually the fear of HIPAA is worse than HIPAA itself, but it's risk management people in different organizations are so afraid of it that they kind of internally restrict, I think, beyond what the rule of the regulation is. But it's really a challenge because this is so revolutionary. The information technology is so revolutionary, and medicine is so kind of more reactionary and conservative about changing culturally. I mean, it's amazing how long it's taken for electronic health records to become used and that. So I don't know if there is a good answer for that. It's always going to be this tension, right? And so there's this principle, and then we'll get this about security. There's a principle about radiation protection limits. This is one of the obscure things I learned doing the space stuff. But it's called the ALARA principle for radiation exposure. When you're setting radiation dose limits over time for people working with X-rays or working with other radioactive substances, it's called ALARA. As low as reasonably achievable is what sets the standard. And so I think that's probably a more sensible, maybe a sensible approach to regulation is, yes, we need to keep patient privacy and security in account, but what's reasonably achievable? Because what I'm afraid of is that what usually tends to happen is we become so restrictive that then the benefit is diminished, right? So the real benefit here is to getting healthcare services to people that aren't getting them now. So it's an interesting tension. Maybe I'm dancing around, but I think that I don't think there is a clear answer. Gustavo, you want to add?
I cannot speak about the US, but I can tell you in Latin America, we have seen many governments and congressmen working on this already. And they have made some interesting progress, mostly in the telemedicine practice, not necessarily in the management of data. But in terms of telemedicine practice, we know there are initiatives in many congresses around the region. We have even helped some of them with some ideas, and we have compared notes among countries and presented different initiatives. There is always the fact that technology sometimes goes faster than regulation. But the other conclusion that we arrived was that you can really implement today telemedicine programs working around the current regulation. You don't need to change the regulation to have implementation with telemedicine programs successfully. That's our experience. And at the same time, the implementation helps the governments and the regulators to start working around it and to start developing new regulation that will cover telemedicine. So we are not really seeing a major barrier in regulation so far.
Well, Gustavo, do you think maybe that's because of something else you mentioned in terms of that home health isn't quite there yet?
Yeah.
Because the way we manage risk right now is we have provider-to-provider communications, right? So we may have a specialist that's remotely examining a patient or reviewing the results, but the information, the recommendations for prescriptions, things like that are being relayed back to that for most of our customers, to the primary care provider. and then they are using their medical judgment based on that. So the risk is much more mitigated there because you've got regulated, certified health professionals at both ends of the system that are governed by HIPAA and these other things. When you start opening it up where you've got many-to-many relations, where you've got, I don't know how many patients connecting with whoever they end up connecting with, I think that's when you really run into the problem. And I was kind of curious, who are these cardiologists that are reviewing these EKGs now to these clinics? Are they Medtronic contracted physicians in country or at the home office?
No, in this case, we've actually contracted that out with outside agencies that actually have that as a company in their own regard. Yeah. You know, and to that, the only comment I would make to your question, Ruben, first of all, is that as everyone says, there's no answer to that question, right? But I think that there's a progression that's happening. There is becoming more harmonization of processes, regulatory processes around the world. As the FDA gets closer to European standards, or Europe gets closer to the FDA, however you want to look at it. Right now in Latin America, Mexico, Colombia, Chile, and Peru are entering into a regulatory framework with mutual recognition of their approval processes. I mean, as we get more harmonization, it will become less important whether it's the FDA looking at it or if it's Anvisa or it's COFEPRIS or whoever it is, because it will become more harmonized. But I think the other statement I would make about the room that we're in right here, there is no answer to this. It's clearly going to be a huge technological challenge, and it's, I think, one of the big opportunities for people in university settings and young entrepreneurs that are trying to figure out how do they add value into the value chain, is going to be to figure out how do you manage all this health information that's going to be coming up. It's going to represent a real opportunity for people.
Well,
the reason because I put this on the FDA is because the operating system for 88% of the telephones running around the world are US operating systems. So I figured out that most of the applications for healthcare will come out from this country to the European group. 5 years ago, the Europeans or the Canadians dominated the operating systems for the telephones. So I see the telephone like the device, wearable device that everybody will have on top of us. And then most of the application for healthcare will come out from the United States. That's my...
right. But the interesting thing is that from a regulatory standpoint, the FDA is probably become slower than the European regulatory. So I know we've done some things at the university, not related to telehealth, but related to other health carriers, where we've actually gotten things European certified in Latin America to use as the clinical data then to get FDA approval. So we've done some cardiac, like percutaneous valve replacement procedures and that in Colombia under clinical trial under the European Union standard, and then use those as pilot data to get FDA approval. And so I think some of this innovation may actually, maybe in reverse, may actually happen faster in Latin America than it happens back here because the FDA has become quite onerous, I think, in regulation. We had a cluster of questions or comments up here in the front too, and I know there's another one here. And to remind you, we will have a reception afterwards, so I know I'll stay for the whole thing if you have questions for me, and I think everybody else will be here.
Scott, I wanted to follow up on the gentleman's question because I think it's really good and I think it's spot on. I think 2 or 3 years from now might actually be a little too late. I think, if I remember correctly, Apple's about to release an iWatch. I would be really surprised if it's not an iWatch with a iHealth or a iFit type module similar to the WithFit. So I think that telemedicine might start going not even to the home right away, but to the individual via the mobile phone. And I wonder if they do so, it's no longer going to be black and white. It's going to be a huge gray area in the middle where we're not talking about necessarily a diagnosis or a prognosis or a prescription, but just simply an alert. I mean, why can't industry right now equip the iPhone and an iWatch with monitors to monitor your pulse and give you a warning, go see the doctor, you might be having a heart attack. Or with a blood sugar monitor, hey, your blood sugar is low, get some, for diabetics, get some food on you or whatever. So I think there's probably a huge gray area between what can be done with telemedicine, if it requires a doctor to diagnose and prognose and prescribe, and everything else that maybe Medtronic is interested in doing as you continue to push the envelope. I hope you're not going to be, limited by just what ends up in a doctor's office, but also the individual making decisions for himself.
You're absolutely right. I mean, this is exactly what I was referring to about the mountains of clinical data that are going to be getting generated. Where does it all go? Because absolutely right. In the future, I mean, forget about the clapper or the first alert that you wear around your neck. You should have something implanted in you, and if all of a sudden your heart stops, it dials 911 for you. You don't have to hope that someone else is there with a cell phone, right?
Right. Yeah, and that gets into how you classify devices, whether it's a wellness device or whether it's actually a class 1 or class 2 device. I mean, so a lot of those apps can do that because they're not really giving you medical advice. They're just logging information, and you individually might set alerts based on certain things. So yeah, well that's the other thing that we haven't gotten into, is that we may be able to automate some of as we can process things more and more, we may be automating the brains a little more or augmenting the capacity of healthcare workers' brains and maybe taking the load off them. So a perfect example is some of the work that's being done in mammography. Right? So someone who's reading mammograms, they get foggy based on reviewing all these normal mammograms, and it leads to missing abnormal results occasionally. So there have been systems that have been developed and now are in use that actually do the automated first screen to identify potential areas of concern, and then that's what the experts focus on are those abnormals, kind of management by exception kind of thing. So that's another efficiency aspect that we haven't really addressed is automation. I'm sure you have a lot of that built into your systems. Oh my goodness. Oh, okay, we'll go to the back because that's where the mic is. I'm sorry.
Yes,
I just control this mic.
Hi, I'm Alejandro Badilla. I'm a surgeon. I noticed I'm conspicuously absent as physicians, and I noticed also healthcare plans. So what my question is for the panel is we've got logistics, we've got medical device, we've got supercomputing and telehealth, but all of those processes are going to be very difficult to bring to the public and to bring to the benefit of people if we don't have the providers and the people who are paying for all of this. So the question to all of you is how can we realize these incredible advances if there's so much, I mean, HIPAA's one, if there's so many things standing in the way of making healthcare more efficient. I mean, we're about to embark in this country in something that's going to make it incredibly inefficient and more costly. And yet we've got things here that can actually make it less costly, but there's barriers that seem to be standing in the way. And right here we've got two groups who aren't even in the discussion who are critical.
Wait, I don't think you can say they're not in the discussion. I mean, I work for the University of Miami School of Medicine. We have physicians inside and out, up and down, and it's like that throughout the telemedicine community.
Yeah.
As well as payers. They're not part of this panel.
Right.
No,
No, I'm not saying the panel. I mean, even the general discussion.
Right.
I'm just saying that what I'm saying is we have something here that is incredible.
Right.
I mean, it's eye-opening to, I think, all of us. But I'm just wondering how we're going to be able to implement it.
Well, what's interesting is payers are now starting to approach us. So one of the things in the state, and so there are a couple national payers that are actually contracting with their own contracted telemedicine physicians. So I know United Healthcare and Aetna are both starting to do that. So, that's an interesting thing. But now that we're looking to privatize Medicaid in the state of Florida, and those Medicaid managed care contracts are going to be awarded, the companies that are bidding on those contracts realize that they can't make it economically feasible without telemedicine because they can't provide the specialty care that's required at all these facilities. So they're starting to approach us saying, can you help us out? We would contract with you to provide specialty services to our Medicaid beneficiaries. So that's starting to happen. But what's interesting is there's a large part of resistance is in the some of the physician guild organizations. So state boards of medicine, medical specialty societies, that are the ones that are lobbying against some of these changes. For whatever, I'm not going to suggest what the reason is, but I think there's some, if you're in a field, let's say like dermatology, and I can artificially restrict the number of available dermatologists by limiting residencies in one, and then I can restrict it further by not allowing cross-border or making it more difficult to do cross-state border telemedicine. Then I further restrict competition. So there's some of that too. So there's some resistance that's active in the physician community or organizations that represent physicians that are also one of the barriers as well.
I'll make a comment there. I agree 100% with the sentiment of your question, because it, you know, as our future President Hillary once said, it takes a village, right? You know, we probably do have to be doing this all together, and it's why I think that having a discussion like this is so helpful, because unless we all participate in this discussion, we can't get anywhere. Technology by itself is just technology. It all relates to actually having people who are effectively trained to use it and people who understand it well enough to know which technology they should be supporting or not. And so that's what I think is the value of these kinds of discussions, because it gets everybody into the dialogue.
Absolutely. And one of the challenges is, as you know, there's not a lot of room in your education to fit additional things in. So we're starting to have residents rotate through our different residencies, but try to get anything additional into the medical school curriculum or a residency rotation is really difficult. So yeah, you're right, it is. But I think it's becoming more and more the standard of care. And I mentioned dermatology because we do a lot of teledermatology. But it's interesting that we get residents coming in now interviewing that already have telemedicine experience, right? And as they're interviewing for jobs post-residency, that's one of the questions they get asked: do you have experience doing teledermatology? So I think we're on the cusp of that changing. I understand we have time for one more question, and we have our special guest coming in from Brazil. There's a very enthusiastic hand here.
Thank you very much. Good evening. I actually have one question for the whole panel. The talk is about enhancing access to healthcare in Latin America. I work for a nonprofit, so that might give you some idea why I'm asking this. If we look at Latin America, there's a lot of people living in poverty, but in particular Haiti, it's very different. So I would like to have your vision, or how do you see from your companies that you could apply your guaranteed access for people in Haiti, considering how the government is or the lack of it, how we can bring access for health, which is a basic right or need, you can say.
Well, I'll address this first, since I have some experience working in Haiti. Haiti's a mess, right? So honestly, you want to know, the unfortunate answer is until we get a more effective form of government in Haiti, I don't think the outlook is very bright. But that said, it's amazing the amount of charitable donation went in after the earthquake. And it had some interesting effects. So one of them was displacing Haitian national physicians who had patients with insurance who could pay for their care but opted for the free care instead. That was an interesting side effect that happened. So I don't know if there's a good answer to that, but I do think that we can use health IT and telehealth to optimize the goodwill of people that want to go in and volunteer to provide care. So we were talking about this a little before. So our pediatric neurosurgery group's been going to Port-au-Prince once a year or twice a year for 20 years doing charity hydrocephalus surgeries, water in the brain surgery, relief surgeries in Port-au-Prince. And the challenge is they can only literally, they're carving out a week out of their surgery clinic to actually go and do this, and they end up spending the first 2 or 3 days ruling in and ruling out people to do surgery. They can only do surgery for the couple days, and then they're gone, right? And then there's no follow-up on the other hand. So we can, one of our visions is we can use information technology to optimize the amount of time that's actually spent in country, right, actually on the ground, but then actually we also feel that physicians would be more willing to donate time if they didn't have to travel. So let's say it's at a low level, maybe it's 5 or 10 hours a month that they provide some sort of medical advice for free, but they don't have to take a week out of their schedule and go through, get their shots, their visas, do all this other stuff associated with doing that. But unfortunately, I wish there was a better answer, but this is partially from real world experience, watching NGOs argue over who's going to get credit for things and not working together instead of helping people. So I've got a little bit of bias towards some of these large NGOs with big marketing budgets and seeing what actually, really happens in a disaster. So that there's even politics and charity, right? So.
Well, I'll make the addendum comment that, your question I know is focused heavily on Haiti, but the issues, the healthcare issues in Haiti, while maybe more dire, are really no different than healthcare issues that would be clear in sub-Saharan Africa or in a small village in Bolivia or any place else around the world that doesn't have adequate healthcare. And while we as profitable companies, I think, have a moral obligation to do a substantial amount of philanthropy, the reality is the healthcare needs around the world cannot be solved by philanthropy. The healthcare needs around the world have to be solved by systems being put in place, governments being willing to support the health of their populations. Philanthropy will never get there. There's just not enough donation money in the world for that. We have to work with governments. We have to develop products that treat patients cheaper than the products that were in the past, and using telemedicine, using other technologies to do it. But we have to find ways to be able to treat patients cheaper, but then we have to be working with the organizations and the governments and NGOs and everybody else to try to figure out ways to actually create funding for those therapies as well, because there's just not enough philanthropy money in the world to do it.
Yeah, I guess from a, you should speak in Haiti specifically, within DHL we have a disaster relief organization that within our culture of our company, we call it Go Help. And we take that very seriously, and I think the comments made by my colleague here are very, very important, right? It's not about us, it's about really reaching out. And within the life sciences and healthcare sector and the disaster relief organization, it's a specific group that does nothing but travel around the world to impoverished areas or areas of need. And it is embedded. And it is, I think it's within many organizations, the infrastructure or the DNA of a company, and we take that very seriously. And being a logistics provider, the world's largest, we try to be there first, using our infrastructure and our technology to allow us to do so.
Just to add to these comments, when we worked together with the University of Miami on Haiti, we also donated telemedicine equipment, and at the time of the disaster, that really created a lot of impact. We have seen amputations saved, we have seen a lot of treatments or diagnosis provided by specialists from the US, and it really helped a lot the imminent risk for the patients in Haiti. I think now the challenge is how to move from disaster relief to a permanent modus operandi that will help Haiti, and I think that's the challenge. The technology is there and the connectivity is there. I think it's more about designing the right model and designing the right incentives for everybody to participate appropriately. I think that will be a private-public challenge to develop together. But certainly the technology is there.
Thank you, everybody, for your attention. And we have a special guest that will be coming in by video from Brazil that Gustavo will be introducing. So thank you for your time and your attention, and we hope you stick around for the reception after our next special presentation.
I think it's very relevant that we have this speaker in front of us right now, hopefully, because many of the questions that you made were touching the regulatory piece, and Rogério Carvalho is a congressman of Brazil, and he's also a medical doctor by training, so he has a very powerful combination of being someone in the Congress trying to push the innovation and the use of technology for healthcare, and at the same time he's been a doctor, and he's also held positions in the healthcare system in Brazil. He has been Secretary of Health of the state of Sergipe. He has been implementing many innovations, and he was really a pioneer in the use of technology. So I think his perspective will add a lot of value and will probably solve some of the questions that you raised about the combination of regulatory with the implementation and the practice. Rogerio has been elected to Congress in 2010 for the Work Party, the government party. And before, he's now in Congress for his term of 4 years, and he's now also pioneering the telemedicine efforts in Brazil for the Sistema Único de Saúde, the integrated system of health in Brazil. So I think it's someone who has a lot of knowledge and a lot of experience to tell us, and I would be honored to introduce him. I hope we can connect with him through video. And he's going to speak in Portuguese, so we are going to have some simultaneous translation. So I ask you for your patience. And again, Rogerio, it's my pleasure and my honor to introduce you. The floor is yours.
Tanto preventivas quanto curativas, e como pode ajudar a reduzir. O Brasil, como todos sabem, é um país continental com 200 milhões de habitantes,
200 million
quinta
inhabitants.
extensão territorial
Many
do
of
mundo.
these are the fifth largest in the world. We have the United Health System that is universal. In addition to being universal, it gives each citizen what they need in each moment of their life. So our health system is integrated and universal. To intensify the care to the destitute population. We have the provision in terms of our population in about 20 million Brazilians, and who have more than 50 years, and this requires that our United Health System requires more of it in hospitals and instruments, and we need more technology. In addition to this, we still have some areas that with great problems, such as dengue and yellow fever. More and more, we have people in the Amazonas. We have malaria. We still have the Chagas disease. And it's a reality that Brazil has from the standpoint of epidemiology. Our dynamic, it tends to reduce the base of the pyramid.
Jim, David, Scott, and Gustavo, and all of you for your time, our partners, and we hope you'll join us for a reception in the lobby. Thank you.